Welcome everyone to an episode of Scoliosis Dialogues. This is Terry Ishmael from the Shriners Hospital of Children of Philadelphia. Today I'm excited to have Dr. Javier Pizones with us. He is a pediatric and adult spine surgeon from the Hospital Universitario La Paz in Madrid, and he's actually the recipient of the 2022 Directed Research Grant for his project titled Self-Perceived Health Status and Healthcare Consumption of Idiopathic Scoliosis Patients Treated More Than 20 Years Ago. How much do operated and non-operated patients differ? So welcome, Javier. Happy to have you here.
Hi, thank you very much, Terry. I'm very happy to be here with you guys too.
Well, great. So why don't you tell me a little bit about yourself? Like, why'd you choose medicine? How'd you get into orthopedics, and why spine surgery?
For sure. This came long way back. I'm 49 right now, and when I was born, my grandfather was already a doctor, and I was the smallest of his grandkids. And my parents tell me that when I was really little, he used to sit me on his lap and tell me, "You're going to be a doctor. You're going to be a doctor." And that happened. So so long I can recall, 4 or 5 years, I already wanted to be a doctor.
Yeah.
Yep. Amazing. Actually, when he died, I was 7 years old at that time, and my parents tell me that I wrote on a paper and put it on the door of my room saying, "Dr. Pizones is no longer with us, but I'm here to take his place, and if any patients need any care." And I was already 7 years old. So
well, that's fantastic.
The beginning. Yeah.
Well, that's amazing. What type of physician was he?
He was general medicine, and then he became endocrinologist when there were specialties in the 60s. Yeah.
Yeah. Well, that's amazing. So how did you choose orthopedics?
Well, I was interested in general surgery. I was interested in pediatric surgery too. And but at that time, I was really into basketball, and I was a sport guy. And I guess that if you liked surgery and you like sports, everybody goes to orthopedics, I guess. And that's the way I got in.
Yeah.
I was raised and born here in Madrid, and I stayed high school and everything, and university and college I did in Madrid too. And also I did my residency in Madrid, so I've stayed here for my whole life.
Wow. And then, amongst all the subspecialties in orthopedics, you were drawn to spine surgery. Why is that?
I did. So my mentor was Enrique Izquierdo, who's still alive. He's retired. And he became an SRS member in 1985, so long too. So since I was little already in orthopedics, I was hearing talking about Harrington, Mo, Silke, Winter, Asher, Dubusset. So I grew with these guys until I got to meet Dr. Linke. So and that I got excited with that. He did a lot of anterior approaches as I liked general surgery. So I got interested on that. And there was a spot free when I finished my residency, and I got into his spinal unit. And there I stayed. And then I changed hospitals 8 years ago, and I'm working in La Paz, as you said, is a very big hospital we have here. We do mostly deformity, and we have 50% adult and 50% pediatric cases. So I'm very happy.
Yeah, that's amazing. So you're able to take care of everyone from like the early onset cases up until the adults. I mean, that's amazing. That's amazing practice to be able to have.
Yep. From 0 to 100, whatever you give me, I'll try to do my best.
Yeah, you can see them for their entire life. Well, so let's dive into your project. So, this is, an amazing project. I went through the proposal, both the abbreviated one, and I went through the full one. And I mean, it's amazing. It's pretty, ambitious. Like, we're going to talk a little bit about that. But why don't you, how did you first come up with this idea, and, what did you do to prepare for it?
Well, the thing is that we already had a pilot study going on. So we were awarded a couple of years ago in the SRS grant, new investigators. And we had a project. So Madrid is very linked to Barcelona, where MBBS is. So we work together a lot. And we together got this project of the SRS that was seeking patients already operated 25 years ago. And see the health status that they have right now and compare it to general population of the same age. So we already had something going on. It was only on surgical patients. So when this idea came out and we had to apply for the project, we already had the idea. So we had to add only the AS conservative treated patients. Another thing that we're looking for is to be very multicultural and multinational. And that's so we broaden up the centers. And finally, we got a consortium of 13 different centers. So all around the world, we got Japan involved, China, people from India, Europe, of course, England, Switzerland, Turkey, Spain, France, and then we have another center in the States. And that's how everything started.
Yeah, that's fantastic. I mean, to be able to organize everybody, I know they can be a little bit like herding cats to get everybody in line to be able to, set
that's the hard part. Yeah.
Oh, absolutely. I mean, this is an amazing project. Now, this was a competition, right? So, how did it feel when you got the confirmation that, you won?
Well, you can imagine.
Yeah.
We were really happy because we know that this has been very hard to obtain. I think we were 15 or 16 different projects that went on. Then we got the first phase. We passed it. I think it was 4 different projects that got on. And at the end, we were the winners and we were really satisfied. So it's very difficult to get this. And I know the other guys have pushed a lot and they were very good projects. I guess that having a pilot study has helped a little bit, I guess.
No, absolutely. And it definitely shows that you're able to get things off the ground and get them moving. And that's a really big part of it. Now, so what is the importance of a study like this? I know we have a couple of natural history studies from like Weinstein and others who've kind of looked at the natural history of scoliosis. How do you hope to build on what they first kind of started?
Well, that's the thing. So we looked up to what we had already in the literature. And as you said, we had the Iowa papers from Ponseti and Weinstein. And then here in Europe, we got those from Nackenson. These are already 20 or 30 years old, and they were focusing on surgical and non-surgical patients. They were not covering it to the normal population. So we still have a void there. So actually, if you see, we treat patients when they're adolescents, thinking that we are going to improve their quality of life 20 or 30 years on the road, but there's no RCT done in that. So we don't have specific data on that. We think we're changing natural history. We think we are improving the quality of life, but actually we still don't have any proof if surgery is better than not doing it, or if any of those are better or at least equal to what the general population has in terms of health questionnaires, in terms of back pain, in terms of socioeconomic status, working abilities. So there's a lot of things that we want to look at.
Yeah, I mean, it's a really big project. So, and your objectives are, I think you just kind of went through them a little bit, but what types of things are you going to be measuring and how are you going to be comparing them?
Yeah, so we are going to have 3 different groups. So the first group will be people treated in the adolescence conservatively. The second group would be people treated in adolescents surgically, and the third group would be current general population to compare with. And we will look through the x-rays and what we did in the past, treatment in conservative, like braces, time of bracing and everything, and surgery, and certain surgical intervention and variables in surgery. And nowadays, where we're going to get all those patients, so we have to call every patient, tell them to come in again, do a face-to-face interviews, and then we're going to make new X-rays, new MRIs to see how the lumbar spine is. We're going to take clinical pictures and see if we can do some body imaging with the pictures. Of course, PROMS, ODI, SF36, SRS22, the TAPS questionnaire is going to be given to. And then the other part is health consumption. So how do they sleep, the quality of life they have, activity they do, disability. So we can compare that to governmental databases that we already have in existing general population not having scoliosis. So the main objective is to see how they compare conservative to surgically treated. And one important thing is that to be included in the database, the original X-rays should have a Cobb angle greater than 40. So if you took a branch of conservative and a branch of surgical, at least to have some similarities in the background deformity. And then compare it to the general population. So compare among them and compare to the general population. And there's other two objectives that we have, now that we are very multicultural, is seeing if we have any differences in between centers or nationalities. And the other thing is identify geographical cultural differences and predictors of long-term outcomes to see what we're doing is the way to go.
Yeah. One thing I picked up from reading the proposal is that you're looking specifically at third generation implant systems, right? So no more Harrington rods, because that's all the old studies were like, I think, Harrington rods and Cottrell-Dubusset systems. So we're looking at pedicle screws and maybe some hybrid systems and stuff. So it's going to be a little bit more relevant to what we do now.
Yeah, we will try to look at that because we're not using Harringtons anymore. So no, we're not distracting only the concavity. So we want to see what we're doing right now, if this is worth doing it, if we improve their quality of life. Yeah, that's right, in the long term. So, and what we have already with 3-generation studies, we have MRIs, 20 years, 10 years, and 20 years of follow-up. We already have that, but we don't have the quality of life, the comparison with the normal population. We don't have data on body imaging with the pictures and mobility, for example, is another thing we're going to look at. Neurological body appearance, sleeping disorders, pain. So I think the project is huge. Let's see if we can get to the end with everything we're expecting to have.
Yeah. What kind of timeline are you expecting?
So we have 3 years already gone. 9 months have already gone, and we are still in the RB approval and contract with every center. This is getting slower than we thought. We are starting recruiting people this January, actually, and we have 2 years to recruit, and then we have final 6 months for data analysis. So all in all, it's going to be 3 years.
Okay. And then how did you decide on the centers?
Well, the project is based on the centers. We are like a family in the ESSG, so the European Spine Study Group. Ferran is the leader. I'm one of the PIs. Ibrahim Obed, Ahmed Al and I, Frank Kleinstuck, the other 3. So we are already 5 big centers working together for the last 10 years. Yeah. We are incorporating now Strasbourg as another center and Nottingham. So we extended that to Birmingham and to another center in the States. We have very good relations with St. Louis. So St. Louis came in with us, and then Ferran has a very good relationship with people in Japan and China. Kenneth Chang is going to be one of them, and then Raja Sekaran in India, who's an expert. Those guys are experts on MRI findings 20 years after surgery. So they already know, they have the classification, they have the people that they're going to be looking at the MRIs.
Yeah. I mean, that's amazing that you've been able to kind of like put this together. Now, what kind of difficulties have you faced, and how did you overcome them?
Difficulties is, as you said, we're a lot of centers and multicultural, multinational, and just to write the contracts with the legality and the regulations of each country is being hard. Is really being hard. It's not being easy. That is one of the difficulties. But we're going by. Already 85% of the centers are already enrolled and with all the paperwork already done. Then we have to train. Every center has to have local coordinators that we have to train them. We have a general coordinator also. We also have a central coordinator that is going to audit everything that we do, and he's going to make reports every 6 months that we have to report. But workflow, we have some workflow concerns. So how everybody's doing with this is a very huge project, and it's going to be difficult to keep the pace with everything. Heterogeneity of data collection and assessment is also another important issue that we have to deal with. Another thing is budget, because although the budget that the SRS has offered and we have been awarded with, almost 90% of the budget goes to MRIs, because we are planning on doing 2 branches, 400 patients each branch. So this is 800 patients, 800 MRIs. So most of the money is going out for that.
Yeah, that's what I figured. That was another question I was going to ask, like, where's most of the money going? But you answered it for me. Wow.
Yeah,
I mean,
because
again,
yeah. Oh, sorry, Terry.
no, you go ahead.
The centers that we're counting in the consortium are centers that already have a big research group. So they already have local coordinators that we don't have to pay for. They already have the machinery going on, the databases and everything. So almost all the budget is going for MRIs and then for data analysis with a statistician.
Yeah. This is an amazing project. Now, do you have any thoughts as to what you're going to see? Any idea as to, like, what direction this is going to go in, or is this kind of just, wait and see?
Well, we already have from the pilot study, we have already closed the involvement of the recruitment of patients. Now we are in stage of analyzing the data. So we already have 200 operated patients with more than 20-year follow-up. Actually, the mean follow-up is 30-something years. So we got people operated 35 years ago.
Wow.
So we already have a notion when they come and we interview them, because this is a very face-to-face 1-hour interview with these guys, how they feel, what they've lived, if they got married, if they've got a job, not only if they have pain or they fill in the problems, but we have a lot of information of just how life has been doing. And in most of them, and I'll tell you, if I can summarize everything in one sentence, is that they already have and still have a scar because of scoliosis. So they don't feel the same as peers that have not gone through this. They have done a normal life. They have many of them have kids, but others don't want to have kids, not to pass them this pathology because they have suffered so much. Remember that in the 80s they used a lot of casts. So whenever you got operated on a heart, and you had to stay in bed and with a cast, and for them it was very difficult. And the jump into a 3 generation, so that when the CD came in, for them it was very important, because that meant that the post-op period was lighter, much lighter. So a lot of people jump into surgery just because the new things, the new technical things that we had at the end of the 80s. But actually, most of them have, as I said, they have families already. They have had some children. They do normal life, but they always have to take care of themselves and do sports, and they're limited by pain, many of them. And let's see. This is the surgical ones. Let's see what has happened with the conservative ones. So, very interested to know what is going to finally come from all of this.
Yeah, I mean, I think that's the most important part, right? Kind of being able to compare them, because it's always it can be a little difficult in the discussion with the families. They're like, well, is this purely cosmetic? Is this just because of my child doesn't like the way their back looked, or does this have long-term ramifications for their future? That's amazing, man. I mean, anything else you want to share about it? I mean, I think we've covered most of it.
Well, the thing is to say thank you to the SRS, on all the organization and the committee for making this possible. So without this budget, it's impossible to get into this big project. That actually we've called this the History Project. It comes from health idiopathic scoliosis treatment over the years. So that all together comes with a history thing. And so thank you very much for the SRS, so I can give some knowledge of this history of these patients and what is happening with them.
Yeah, I mean, that's fantastic. Thank you so very much for joining me today, and look forward to hearing more from you in the future.
Thank you very much. I've been very comfortable, Terry. Thank you for taking your time with me.
Yeah, great.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.